So let's talk about emphysema. Emphysema is a little different than the chronic bronchitis. Most of the patients you see, chronic bronchitis, you get that especially in the wintertime. You get a lot of chronic bronchitis patients, get that mucus, great big mucus production, and then a lot of them think it's a pneumonia perhaps, and sometimes it does work into a pneumonia, turns into an infection. But the emphysema has been, it's been tagged as the cigarette smoking disease. I only know a few people who have emphysema that didn't smoke, and those are guys who didn't wear respirators when they were working, like painters and people in factory factory workers that should be wearing respirators that didn't wear respirators, and then they developed emphysema. What it does is it breaks down the wall of the alveolus. You lose the elasticity of the lung won't expand, and then you get all this air trapping in, this bronchospasm, a lot like asthma. You still produce that mucus and swelling in there, and air gets trapped. Very high in CO2. All these guys, you can see the typical emphysema patient because they're skinny. They have that big barrel chest, and they're flushed in their face. They got this red sort of glow to them. And that redness is contributed to the increase in carbon dioxide that they build up in their body. One thing that we look at, we breathe normal breathing, unless you're like you're chronic, closet chain smoker. You probably went out to your car during break and smoked too, right?
Yeah, exactly what I did.
That's what I thought. So, with the exception there, we all breathe on what's called the hypercarbic drive. So we breathe on a drive in response to carbon dioxide. So once carbon dioxide builds up too much in the body, the brain says, take a breath. And it keeps that carbon dioxide level between 35 and 45. And that's the way that we normally breathe. It's on the level of carbon dioxide. The problem with these guys is that their level of carbon dioxide, because of the emphysema, is so high all the time that they have to breathe on their backup drive. And the backup drive is the hypoxic drive. They breathe on a response to oxygen and not carbon dioxide. So do you see the problem with that? Because when you go out to their house and you have this emphysema patient, they're in severe respiratory distress, what are you going to put on them? Right, you can't deny anybody oxygen, right? You gotta give the patient that is having difficulty breathing oxygen, or you're violating the standard of care. But what's the problem? Right, they stop breathing because they breathe on a response to oxygen. So if you start raising, room air is what, 21%. So now you put a non-rebreather on them at 90 to 95%, and their body essentially goes, I don't need to breathe. I've got enough oxygen. And they stop breathing. So what you want, because now the question is that a problem? Is that a problem if they stop breathing? Let's see. Is that a problem if they stop breathing? What? Do you agree?
Teachers, please.
What about you? You agree?
Girls basketball
Probably
is
stop
just returned
breathing.
to campus. All girls basketball should be in class within the next 3 to 4 minutes. Thank you.
Problem if they stop breathing?
No.
Why is it not a problem?
They have the oxygen.
Okay, you can take them off the oxygen, but now they're still not breathing, so is that a problem?
Yeah, because they build up toxin.
Is that a problem?
No, because they have a thing about swimming.
No.
No.
Don't overthink it. Right. It's not a problem because we'll take out our bag valve mask and breathe formal. That's someone in respiratory arrest in an ambulance is not a big problem because we're breathing for them. So if I'm bagging them or you're bagging them, are they breathing?
Mm-hmm.
Yeah. They just have your help breathing. So here's the thing here. You can't, if you've got this person that you've identified, and they will identify themselves. They will say, oh, I can't take that non-rebreather. You know, you don't put that non-rebreather on me. Some of them will have a card from their pulmonologist saying, do not put high concentration of oxygen on this patient. But now you're sort of stuck in this gray area because you're treating the patient and the patient requires a higher concentration of oxygen. They're breathing through their mouth. They're having respiratory distress. Nasal cannula won't do any good. You don't put the non-rebreather on them, you're in violation of standard of care. In your protocol says someone in respiratory distress, give them oxygen. There's no if clause in there, right? So you give them the oxygen, and sure enough, if they're this, it's called the 50-50 club. We won't get into that, but it deals with the oxyhemoglobin curve. If they're in that 50-50 club, more than likely, and they're breathing on their hypoxic drive, and you put a non-rebreather on them, more likely they're going to stop breathing. Now, you were right that you can remove the oxygen before they stop breathing because you watch their heart rate. The heart rate and respiratory rate are proportional. So if your respiratory rate is up, your heart rate is going to be up. If your respiratory rate is down, your heart rate will go down in normal circumstances. So you watch their heart rate, and if their respiratory rate is going down and their heart rate gets too slow, they start getting bradycardic, they're about to stop breathing. So you watch that rate, and if that rate falls, and if they're still breathing rather fast and their heart rate drops, then they're about to stop breathing. And usually to get bradycardic, their heart rate will slow down way slow.
But one causes the other, or it doesn't matter? Will making the person breathe more bring up their heart rate, or bring up their heart rate and make them breathe?
Well, they're about to stop breathing because the oxygen, not necessarily the stress, but the amount that you're giving them that oxygen that they don't need. So they're going to stop. Well, they need oxygen, but they live in that hypoxic drive, so they're responding to that oxygen that you're giving them, so they're about to stop breathing.
So you're going to get in trouble even though they say emphysema, like they have high concentration of oxygen, you won't get in trouble even though they went respiratory arrest because you still put that mask on them?
You're right, you won't, because you have to do what's in your standard of care.
So if that like led to potential, like if it led to their death or something?
Well, and that's a good question. But if you allow them to continue to be in that severe respiratory distress, what's going to happen? They're going to die. Yeah. They're going to die anyway, right? If you allow them to continue to breathe, let's say hypothetically, 50 times per minute, tripoding, severe respiratory distress, and you put a nasal cannula on, which is not doing any good because they're breathing through their mouth, and then they eventually go into cardiac arrest from that, what's the difference? Right? I mean, the difference is that you allowed them to do that. You allowed them to go into cardiac arrest due to the non-treatment. The other way is that you treated the patient according to your standard of care. The patient predictably went into respiratory arrest, but then you started breathing for them. And when you get into that situation, usually you can hold off cardiac arrest because you're fixing the problem. You're breathing for the patient, right? The problem is not their heart, the problem is their breathing. So you're fixing their breathing even though they stop breathing. Does that make sense? ALS-wise, and this would be a case where you'd want to call for ALS backup. because they would just be they would get intubated. We fix their breathing problem by intubating them. All right. So that's a big thing with the emphysema patient, but don't let that trip you up. If someone's having difficulty breathing, put oxygen on them.
So if someone, like, you know how they have a card that says do not place it on your breather? I'm like, if they have like a card like that, but it's like against the end of care, you don't have to abide by the card.
Well, you wouldn't abide by the card anyway because that's not from your medical director.
Oh.
Your medical director's telling you in your protocols what to do. Now, let's say you have a question, what can you do? Let's say you're on the fence, you don't know what to do. What can you do? Well, you can call your medical director and say, hey, here's the thing, what do you want me to do? If the medical director says, well, let's just put a nasal cannula on and bring him in, and if he codes, then you've done what you were supposed to do. And you document, back to that documentation, you document down in there, per medical control, leave patient on nasal cannula and transport. And the responsibility is completely off your back.
Do medical directors get sued a lot?
Doctors in general get sued a lot, yeah. Yeah, just because they have to make the hard decisions, right? So emphysema, typically smoker, you get them, there'll be wheezing, and there'll be, in need of that albuterol that you have. So the good thing about chronic bronchitis and emphysema, the treatment's the same. Do your assessment, get a room air SpO2, put them on oxygen, look at giving them that updraft or helping them with their prescribed inhaler. Right? And so treatment-wise, pretty much the same. And then this is just a picture here. They do build up the mucus production still. They get the air trapping, the bronchoconstriction down in here, which you need the bronchodilator for, to open them up and help them breathe. These guys will eventually get steroids just like the asthma patients. So they're doing pump them full of bronchodilators, give them some steroids, and dry them up. There is a medicine out there, it's called albuterol. Everybody knows should by now be familiar with albuterol, right, or Vinland. But there's a medicine out there that we mix together with it called Atrovent. And it's called an A&A. They might tell you go set up an A&A. So you take Atrovent and albuterol and mix them together in the same nebulized treatment. The Atrovent is a family of atropine, a cardiac medication, but one thing that atropine and Atrovent do is dry those secretions up. So it's not really a bronchodilator, it's not the best bronchodilator, but it helps dry the secretions up so more air can get through. So you may be asked to mix that albuterol with some Atrovent during your clinicals. And we'll show you the two. Questions on emphysema, chronic bronchitis? Very good. Asthma, we have one wheezer. Any other wheezers?
I had asthma since I was born, but I grew out of it because I exercised a lot.
Yours is induced, activity induced, right? Didn't we try to make you run down the hall the other time?
No, that wasn't.
Not you, he's talking to Ethan.
We would just keep running you until you break out this asthma attack.
Cause I think for me,
Take one for the team.
Like in case you find out if you have it when you're like an infant and then you outgrow it, is it called something else? Or is it still asthma?
well, cause I had mine checked last year and they said it's on the verge of having it and not having it.
I had like severe asthma, like in Chicago, and then we moved here, and I never had an asthma attack after that. But like in Chicago, I would be in the hospital for like 6 weeks straight due to asthma. Isn't that weird?
A lot of asthma is what's called an episodic disease, episode. So A lot of people where I'm from in the Panhandle have asthma because of the fact that in Amarillo, 45 miles south of Amarillo, is a town full of stockyards. So when the wind blows to the north, guess what smell we get in Amarillo?
Ew.
You know, well, all that cow poo, all that particulates in the air blows, and you get all this stuff, all this crap in the air, and it causes people to have asthma. But they, like I said, they move away, and their asthma goes away. And it's just due to that episode. Some people have asthma attacks, almost like allergic reactions, due to pets, and pretty soon we'll have a lot of the wheezers just start breaking out because people start turning their heaters on. As soon as they convert from the, you know, people will stop now, like me, you don't have your air conditioner or heater on. But in a couple of weeks, well, a couple of months or whatever, people start turning their heaters on, and all that dust and those dust mites will come out and start asthma attacks again.
When I play football too, like if the air is like really dry, there was not really nothing moisture in the air, then it seems unhappy more often.
So just different things like that, or something like in Chicago, no telling what was floating around the air there. But just different episodes. I've seen people have legitimate asthma attacks over some sort of emotional distress, boyfriend, girlfriend breakup. All of a sudden they start wheezing, having an asthma attack, over grades, over getting in trouble, you know. And these are not like they're faking it. I mean, they're wheezing, they're having difficulty breathing, they're having true asthma attacks. And it's just certain episodes sort of spark it off. Sort of like allergic reactions a little bit. But it's the same way. You get this bronchoconstriction. It restricts the bronchioles. One thing about asthma, the SpO2 is going to, until the asthmatic gets very severe, the SpO2 is going to read normal. Because asthmatics don't have problems getting air in, they have problems getting air out. That's what's causing the wheeze. So their SpO2 stay up quite a bit at first until it gets severe, and then they start going down. So don't get fooled by putting the SpO2 at 100%. And they say, I'm having trouble breathing, I can't get air in. Listen to your patient. Even if there's not a wheeze, they say, I just feel constricted in my chest, like I can't get air. They still need the albuterol, they still need the updraft so to loosen it up. It is very important. The wheeze is a good thing. What don't you want? That's right. That's right. Silence in an asthmatic patient is very bad. In any asthma, emphysema, it's very bad. That means they're not moving hardly any air. They're not moving enough air to produce a wheeze. So that patient that has silent lungs, they're not moving hardly any air. They're about to stop breathing. That's a critical patient. You've got to get that albuterol in there very quickly, or they don't stop breathing. So what happens is, on the silent lungers, you open that up, and then you start hearing the wheeze. So how would you document that? So you do your initial assessment, and there's no air sounds. They're very limited, very diminished air sounds. But you give the albuterol, and now you have a wheeze.
So it's getting better.
Yeah, they're getting better. Even though they're wheezing, they're getting better. So how do you document that?
Patient silent first.
Huh?
What you did, patient silent first. No lung sounds, gave albuterol, these sounds, so it's pretty good because there's more air. Albuterol was administered because of silent breathing and improved with wheezing.
Yeah. So I mean, you got to work it out on how. What phase would that be of your your documentation? Now, your ABCs would produce essentially. I mean, they're breathing ABC. So they're. But in your physical exam, you know that when you auscultate lung sounds, there's no air movement. So you gave them the albuterol, and now you have a wheeze, what part of the exam is that? Starts with an R.
Reassessment.
Right, reassessment. So when you reassess the patient, remember, your initial assessment, your initial exam,
Is how
Right.
they are at that time.
yeah, then you document that, and then you reassess the patient because you've given a medication, right? So after every medication, you reassess the patient, and during that reassessment, this is what you would put down. And there's sort of a picture of it. Here's the alveolus, you get the airway constriction, you get the mucus. But the other thing that is particularly interesting with asthma is the swelling. The albuterol causes a bit of swelling in those bronchioles, but you have to have the bronchodilation. There's nothing that you guys can give for the swelling. So that's why they go to the hospital, and once they get to the hospital, they get a steroid treatment for the swelling. So you've got to sort of dry up the mucus production. You've got to bronchodilate, and then once they get to the hospital, they start pumping them full of steroids for the swelling. And then the asthma episode will go away. It's still there sort of with the swelling, because the swelling causes the bronchoconstriction, correct? So, again, though, the good thing, treatment's the same. Room air SpO2, put them on some oxygen, get permission to do an updraft or prescribed inhaler,
Can you
reassess.
get an asthma attack while you're sleeping?
I guess you could, like if the heaters came on or something. Big sound sleep, heaters kicked down, got the dust. I don't think I've ever.
I mean, because whenever I was little, I don't really remember because I was asleep, but my parents had called the ambulance because I was having an asthma attack.
Oh, yeah, you probably woke you up.
Yeah, you wake up.
You woke up and then you have an asthma attack. All the patients have seem to have been awake. The difficulty breathing would wake you up. Yeah. Fluff your pillow. No, I think you'd wake up. Yeah. Everybody good with asthma? All right. Pulmonary edema, CHF patients, we'll talk about more during the cardiac section. This really fits in there, except that it is a breathing problem. All right. It occurs when you have the patient with congestive heart failure. Congestive heart failure leads to, one, you have right and left heart failure, right? But you get the pulmonary edema during the left heart failure. And we'll pick that up more. We'll talk more about CHF during the cardiac section. But you experience the difficulty breathing with CHF because of the accumulation of the fluid from the backup, from the heart not working, the pump's not working correctly, so it's not pumping the fluid. So you look at the right, and let's take a look at the heart. Let's take a picture of it. That would be the aorta, and then the vena cava, right? Right, and then left. You have these two sections here. Where's the fluid? Let's say because all CHF patients start off with right-sided failure. Right-sided failure leads to left-sided failure. And the left-sided failure is the one that is usually fatal. Where does the blood flow? Let's say the blood flow is coming up here, and you have right-sided failure. Where's the edema going to be? I mean, where are you going to see the edema with right-sided failure? Blood's coming up from where? Yeah, but where's it coming up from? in your low extremities, right? So if there's a backup here, if this right side of the heart's not pumping the fluid correctly to get it all out, where's the backup going to be? In the lower extremities, right. So you're going to get swelling in the lower extremities.
So that's swollen feet.
Yeah, the swollen ankles and cankles, depends on how big, how much the swelling is. So right-sided failure, you're going to get the edema in the lower extremities, or the extremities. These are the pulmonary vessels leading into the left atrium, okay? So blood flow is coming in there. So with left-sided failure, where are you going to get the backup?
Upper extremities.
On the left side, blood's coming back from where?
The lungs.
Right, the lungs. So where are you going to get the fluid back up at? The lungs. So in left-sided failure, you're going to have fluid back up in the lungs. You're going to get pulmonary edema. That's where you listen for the crackles or the rails in the bronchi. That's pulmonary edema. And the problem is the same almost with the mucus production in the emphysema and chronic bronchitis patient, because you're going to get fluid there, and you can't get that diffusion through the fluid, correct? So you're going to get that back up, and so that's the problem with CHF patients in this fluid with pulmonary edema, is that diffusion. There's too much fluid in there. You can't diffuse the oxygen. So this patient's not going to be able to lay flat. Why?
Because he like his journey.
Yeah, exactly. You start laying them flat, they like to sit up at a 90-degree angle. So you start laying them like this, and if they have fluid in their faces, their lungs, it's going to come up here. It's going to give them the sensation like they're drowning.
So wouldn't you have to intubate them and lay them down anyways?
Yeah, but that you give them drugs and they don't care after that. That's the beauty of being able to give drugs. You can lay someone, you can give them some drugs and get them so high they don't mind if they like drown, right? So, but now, what do you do if you're trying to bag this patient?
If they're conscious, can they bag themselves?
No, you don't bag yourself. So what do? You got this CHF patient, severe CHF patient. Let's talk about the next CHF patient. You have him, he's massively got this CHF, acute CHF, and he has bronchi everywhere, and all of a sudden he gets, because the fluid keeps to build, where's it going to come out at?
No.
Eventually it's going to come out the mouth, right? It's going to work its way up the trachea, and it's going to come out of the mouth. So it's called frothy pulmonary edema. You guys like the like cappuccinos? Then you know that white cream that's on top of the cappuccinos?
So it's gonna look like they have rabies.
Yeah, it's you take off your lid, and they got the milk that's
Don't say that word.
spooled up. Yeah, the foam, like right on top of the cappuccino. You know what I'm talking about? That's froth. Add a little bit of bud. That's frothy pulmonary edema. Frothy. So it comes up, and now it starts to, with kids, they used to play with their spit. Y'all probably did it. You sort of get a little spit, and you spit on your chin.
So they look like they have rabies.
And so now you have fluid sort of coming out. It's blood tinged because it's coming from the capillaries, right? So you get this frothy, blood tinged pulmonary edema. Just picture the cappuccino.
No.
It looks the same. Now you have this patient. They're not breathing. Sats are falling. You got to lay them flat to bag them. You can't effectively bag someone sitting up. You got to lay them supine to get them to bag. Put a nasal airway. They're still conscious. You can't put an OPA in. Put a nasal airway in. You try to start bagging them. What do they don't do? Yeah, they're going to freak out. They're going to fight. So now you have a combative patient. They've probably got a lot of cerebral hypoxia going on. You don't have drugs. You're an EMT.
ALS.
No, they need to be bagged. You're suctioning them. You're suctioning the cappuccino out. You know, you're trying to breathe for them.
What is it called when it starts coming out?
Frothy.
No, like, but is there an actual term for it?
Frothy pulmonary edema.
You said frosty.
So, what do? You got that pain? This is a realistic scenario. It's happened to me a gazillion times. Fortunately, I've given them some drugs. But on the EMT side, what are you going to do? Call for ALS backup. You already said that. So now what do you do between the time you get ALS backup there?
Yeah.
So Mama's boy, he likes the frothiness.
I just don't like
She's not looking at it.
So we talked about this. Builds up that fluid level. Extreme dyspnea. When we start looking at it, anxiety, tachycardia, saturation starts to drop, frothy pulmonary edema starts coming out, the heart rate shoots up. When the patient gets really tachycardic, you're in risk of giving the patient a heart attack. So there's several things that you've got to look at there. So most cases you're going to hear rales or bronchi, all right? They may cough, this frothy pulmonary edema, sputum that we've talked about. That's in the most severe cases. So you'd be suctioning, you don't have to start bagging them. But where's the air going? Here's the important thing about here with the frothy sputum. You're bagging them, but you don't have good bag compliance. Because you're squeezing the bag, but where's the air going? What's in the trachea? Yeah, sputum. So they're going to be very difficult to bag because you're bagging into that fluid. You're actually forcing that fluid down. They really need to be intubated so they can do endotracheal suctioning and try to get some of that fluid out and open up the airway. It's a big problem. Big problem for EMTs because of the lack of medications to give them to calm them down. So treat them, high concentration of oxygen, BVM, CPAP would work great there. Put them up on CPAP, force that air into the airways, and try to keep them upright. Pneumonia, anybody ever had pneumonia? There's a couple different kinds. A lot of people get pneumonia and they take antibiotics. They walk around with it. The other kind of pneumonia they get, they go in the hospital. So you can have bacterial pneumonia. Will probably be it's the hospital kind. Viral pneumonia, you can sort of walk around and call it walking pneumonia. As long as you don't be short of breath because that infection growing in the lungs. I think I have a picture of it there. The normal chest x-ray that we look at here. The norm on the chest x-ray, this side is normal. See how it's all black? It's clear. This be the heart. Someone with CHF, try to look at the x-ray sometimes at the hospital while you're there. CHF patients will have this huge heart because of the stretching of the myocardium because of all the fluid. You can sort of see the sternum and the trachea here, but you see the pneumonia right there, that spot. So when they take the x-ray, they look at that and say, yep, got pneumonia. So they start this patient on antibiotics. They still have trouble breathing, difficulty breathing. The difference here at the EMT level, you don't really treat a CHF patient any different than the pneumonia patient. They may still need a bronchodilator. That would help them, okay, if you're able to give them a bronchodilator. But one thing that you're going to hear over here is fluid. So when you listen to that one side with the pneumonia in it, you're going to hear some fluid. ALS-wise, what you have to discern between the two, is that CHF or is that a pneumonia? Because we give CHF patients Lasix or a diuretic to get rid of the fluid, right? That doesn't work there. It'll kill them. So you can't give a CHF patient a diuretic. I mean, you can't give a pneumonia patient a diuretic. So how do you tell? You don't know the patient, you don't pick them up. How do you tell if they have pneumonia or CHF? Well, they still won't be able to. Pneumonia patients, they still have to sit up.
Well, will they still get the drowning feeling?
Yeah.
What did you say?
How can you discern between if this patient is you don't have the x-ray, between CHF and pneumonia?
The sounds. Breathing sounds?
Hmm?
Their breathing sounds?
Let's flip back here. Pneumonia is caused by, let's say it's bacterial pneumonia. What are you going to have with a bacterial infection? Fever. Right. So the patient with pneumonia is probably going to be febrile. They won't be febrile with the CHF, but with the pneumonia patient, they're going to be febrile. The other way, somebody mentioned it, like their lung sounds are the same. When you try to discern if that's pneumonia besides the fever, when you're trying to discern a difference between CHF and pneumonia, you listen here and you listen to this sound here, then you place the stethoscope over the trachea, and it sounds the same. So this airway sound that's coming up the trachea sounds the same as over here for pneumonia. CHF, it won't. It'll be a different airway sound. But don't worry about that because your treatment's the same.
Is it just for the right lung or can it be either or?
Either or. Yeah, so your treatment's the same. Put them on oxygen. If you're able to, give them an updraft. That'll make them happy. Open up those bronchioles a little bit. And then transport. Not too much you can do with pneumonia. ALS-wise, same thing. I just give them an updraft. Take them to the hospital. Or they probably have pneumonia. Don't give them any Lasix, diuretics. So shortness of breath, cough, fevers. So it sounds like they're sick. They could have some pleuric pain or sharp chest pain. This is different than cardiac-related pain. This type of pain is going to be, it's going to increase with respiration. All right, it's going to be a sharp instead of a pressure type pain. So this is different. A pleuric pain is. Anybody ever had pleurisy? Pleurisy is the fluid that's in between the visceral and the parietal pleura, the two coverings of the lung, the thoracic cavity and the lung. There's a fluid there that keeps it nice and lubricated. People who have pleurisy have an infection there. So every time that someone has pleurisy, the patient who has pleurisy, every time that they take a breath, they're going to say, oh, it hurts right here. And that's where the infection is going to be. It's sort of a pinpoint pain, pleuric pain. Pleuric pain increases with respiration. Every time they take a deep breath, it's going to hurt. Sweaty, fatigue. Why here? Why the fatigue and confusion?
Because of fever?
Could be, yeah. Depends on their fever. Huh?
Lack of oxygen.
Lack of oxygen usually. They're not diffusing through that pneumonia very well, so they just don't have this lack of oxygen. Support them, oxygenate them, transport them. Usually have to transport them upright. They don't want to lay down with the pneumonia. The other one that you may see, especially in smokers, especially in emphysema patient, is the spontaneous pneumothorax. A pneumothorax is a collapsed lung. Okay? So you get we'll study more about pneumothoraxes and trauma, but a spontaneous pneumothorax comes from smoking. I've actually had a former student stop her mom at the fire station and have her get checked out. She was a smoker, and all of a sudden she had sort of an acute shortness of breath, and it hurt to breathe in, and she was going to go into work and maybe go to the doctor, call the doctor and try to get in, and her daughter said, no, stop, you're having trouble breathing, and sort of a sudden onset of trouble breathing. They stopped at the fire station, ended up taking her to the hospital, and she had a spontaneous pneumothorax where the lung had collapsed. Tension pneumothorax is due to trauma, and we'll talk about that. But the lungs collapsed here, and the problem with the pneumothorax is the air is going into that pleural space instead of the lung, because it's going to travel down the path of least resistance. And it's really prominent in smokers. And she happened to be a smoker too. Yeah, so sharp pleural pain, decreased or absent lung sounds, very important on all the pneumothoraxes. Shortness of breath, and then the saturations will start to drop because of you're losing surface area of the lung with the pneumothorax. Your treatment is only to transport and oxygenate. Don't give them CPAP with the pneumothorax. You don't want to push air into that pleural space. You'll continue to collapse that lung down. So remember that with the pneumothorax, no CPAP. Just oxygenate and transport. All right, my least favorite thing is the pulmonary embolism. It's the least favorite because most pulmonary embolisms they're fatal. It's where that embolism, it breaks off, it's a clot. You can have amniotic fluid as an embolism, air embolism. That's why we clear out that, remember we learned to spike that bag? We clear that air out. We don't want that air embolism in the body because it could lodge somewhere and then cause severe respiratory distress. What it causes with the pulmonary embolism is what's called VQ mismatch. The V is for ventilation and the Q is for perfusion. So you get a VQ mismatch, which a lot of times is fatal. It's fatal because they appear in severe respiratory distress. I mean, the non-rebreathers doing absolutely nothing for them. You just can't get them to slow their breathing down. So if they can't do this, if they stay in that severe respiratory distress, what's the next thing that's going to happen? Yeah, before that. You're breathing. What do you think's going to happen? You can't get your shortness of breath under control. You're breathing 40, 50 times per minute. What do you think's going to happen to that patient?
Is there like too much carbon dioxide?
You're right. They're going to have a heart attack. So the possibility of this patient over here with this PE, they're having trouble breathing, and they're in such severe respiratory distress, it's going to lead into an MI. And that MI is going to lead into death. Most of them die from what's called a global MI, which they start infarcting just all over their heart. They have this massive heart attack. Let me see if I can get this to work. Not like that.
My mouse.
Maybe that was just a picture. I thought it was a movie. Oh well, bummer. Thought I put a movie in there. Anyway, they're removing this pulmonary embolism from this guy. I'm sure it was a movie. It just didn't embed right. I have to go back and fix it. Bums me out. But you can sort of see here the picture. This is a pulmonary capillary, and that embolism is blocking off that pulmonary capillary, causing that VQ mismatch. So you get the chest pain, shortness of breath, profound cyanosis, very low oxygen saturations, high tachycardias, and all this. They need to go to surgery when they look at it. So you treat it, oxygenate them. You can usually suspect a pulmonary embolism in someone with an irregular heartbeat, someone that like a mom that just gave birth, someone that's been sitting on an airplane, like an international flight. They could do that. They could get a pulmonary embolism from that. Okay, so that you would suspect a pulmonary embolism when the patient presents. They're sitting upright and they're just this profound difficulty breathing. Then your mind should start going. Once they have a PE, then you start looking at all the different things together about the pulmonary embolism, putting together the signs and symptoms. We've already talked about the prescribed inhaler. Remember that testing purposes, you sit there and you ask for medical control to assist the patient with their prescribed inhaler, and then or their meter dosed inhaler. You're giving them oxygen. You're checking it to make sure it's there, that it's good expiration. Shake it up because of the powder inside of it, and then you have the patient take the deep breath and go and push the button, and then have them hold their breath while they're doing that. That way it gets the medicine down inside. If they don't hold their breath, then they're just going to exhale the medicine out, and none of it gets in. Very difficult to give. Here you won't see these on the ambulance. What you're going to see is the nebulized treatment that I'm going to show you in just a second. All right? But read over the steps and the things with the meter-dosed inhalers, because this is what most of the time, this is what you're going to see on the written test. But the nebulized treatment, small-volume nebulizer, runs through the oxygen, it makes a vapor, and with that vapor, the patient can inhale it, and it's a little bit more controlled. Okay?
I have one that's like a little dinosaur mask.
All right, any questions on that? Let me show you what the nebulized treatment